the study which I'm going to discuss is a negative study. It's so important for us to discuss the negative trials as well, apart from the positive trials. So the hypothesis, the concept was very different, like apart from the routine oncological trials where we know where we are targeting, where we are heading in the study. So it's a CANOPU A trial. It's a phase 3 study of Canakinumab as adjuvant therapy in patients with completely resected non-small cell lung cancer. So where does the concept of using Canakinumab? For the audience like who are listening to this, Canakinumab is not an oncological immunotherapy drug or something. It's anti-interleukin 1 beta monoclonal antibody. So from where the concept of using Canakinumab in lung cancer came? It's from the CANTO study. CANTO study is a very famous study which was done in a patient who got a myocardial infarction. It's a cardiovascular disease. Those patients have a raised CRP. We all knew in internal medicine, raised inflammation in the body predisposes to atherosclerotic disease. So atherosclerotic disease, like we introduced the anti-inflammatory marker, the reinfarction rates and all got studied. It's not the small cell lung, non-small cell lung cancer incidence which got studied, but it's the reinfarction rates, other CVA events got studied. But accidentally, when they did the retrospective analysis, they found that whoever received the Canakinumab, the 3 doses they gave, 3 monthly 3 doses they have given, not only just there is a decrease in incidence of cardiovascular events, but also there is a decrease in non-small cell lung cancer incidence and mortality as well. So from there, the concept got picked that decreased inflammation in the body can predispose us to the can decrease the lung cancer incidence as well, because all of us know atherosclerotic disease, one predisposition is smoking. So smoking not only lead to cardiovascular disease but also to the lung cancer. So if we introduce anti-inflammatory, can it like decrease the incidence of lung cancer was the concept. So there they conceptualized it. The role of inflammation in lung cancer, it's already studied and well established. So will this inflammation getting targeted will harness therapeutically is a question. So that's where the idea has come. There are different doses used there also. That is a 50, 150, as well as 300 in CANTO study. So how this study has happened? So the study included the stages, stage 2A to 3B, both all got resected, but whoever are node negative, they didn't receive any chemoradiotherapy, but who are node positive and all like criteria of like fitting into the chemotherapy, giving the adjuvant chemotherapy, they received adjuvant chemotherapy radiation as well. Following that, they received a Canakinumab 200 mg every three weekly. For likewise, they received a 1 year, almost 18 cycles they received. So, and later the radiologically sequential, they got evaluated and survival got a follow-up done for this kind of patients. The primary endpoint of the study is a DFS. Key secondary endpoint is OS, only if DFS is statistically significant. The patient group, like in both groups, both Canakinumab group as well as placebo group, the age, sex, ECOG status very well matched. The predominant population, histology is adenocarcinoma. It's non-squamous cell carcinoma, and squamous predisposes to only 25%. So it's a more of adenocarcinoma group which got included here. And the stage which got included is a 2B and 3A is the predominant group. It's almost consists 80% is a 2B and 3A group. And when it comes to smoking history and chemotherapy, there are former smoker, current smoker constitutes almost 75%. Only the non-smokers constitutes only 25%. Only a quarter constitutes that. And 90% of the patients, more than 90% of patients received chemotherapy in this study. So almost all are like predominantly 2B and like 2A, whoever are eligible to take the chemotherapy, who request chemotherapy. And PD-L1 negativity are, less than 1 are missing is almost constitute 80% again. And CRP level low as well as missing, it constitutes 50%. Half is this category and half is other category. The patient, if you see, they got randomized and they got like complete treatment, and they got serially got evaluated for the follow-up with the different radiological investigation, different time points. If you see the radiological investigation time points, first year, they got radiological evaluation done every 12 weekly. In the second year, third year, they got done every 26 weekly, and later annually in fourth year and fifth year. So if you see this is a negative study, absolutely 2 curves are bang on. There is a minimal benefit is there, which is statistically insignificant. The DFS was not at all significantly improved with the Canakinumab versus placebo. 35 months versus 29.7 months, the hazard ratio is 0.94. And the p-value is 0.25. Clearly, There is no significant DFS benefit. If you see the curves and all, there is slight predisposition, there is slight erring towards canakinumab, but that's not statistically significant. The subgroup analysis also did not show any meaningful differences between two arms for DFS. You see the lung cancer specific survival, again, absolutely no difference. Two curves are bang on. The hazard ratio is 0.90. And OS was not formally tested, as I already mentioned, because DFS was not statistically significant. They didn't test OS again. Only 100 events were reported, 44 in canakinumab group and 56 in placebo group. Lung cancer specific survival is nothing but defined as the time from date of randomized to date of death due to lung cancer was similar between both arms, as I mentioned. No DFS, no LCSS benefit. OS was not formally tested, but tested, there is no difference at all. Or if you see the serious adverse events, the total fatal adverse events are similar between the two arms. Canakinumab did not predispose to any significant adverse events. On-treatment deaths were numerically lower in canakinumab arm compared with the placebo arm. So, what is the most common adverse event one has seen? It's infections were the most common adverse events, and it took us everyone took a special interest that it predisposed to infection. Only 2 adverse events were reported in more than 10% of the patients and were less common in canakinumab group compared with the placebo arm. It's a cough, arthralgia, all these things. But the significant event which caught the attention, which caught the statistical significance is the infections. So what's the conclusion? By introducing this drug with the concept of decrease in the inflammation, the primary endpoint of DFS was not met with hazard ratio 0.94. Even the subgroup analysis was done based on demographics, baseline disease characteristics, and biomarkers of interest. Again, did not show any meaningful differences between the two arms for DFS. No new safety concerns. And again, exploratory biomarker data from CANOPU will continue to be analyzed, including tumor molecular profiling and longitudinal analysis of circulating inflammatory markers. And to reveal the exploratory biomarker data, which is very interesting, which is a bedside medicine, I would say. Can this really convert into the bedside application is a question. But as per this data, the CANOPU, which was like shown here, there is not much benefit. Even the subgroup analysis clearly showed there is no benefit of adding interleukin 1B inhibitor. So the collective data gained through the CANOPU program will provide insights on the role of interleukin 1B inhibitor. So this is a study, very interesting study with no significance and failed to show any benefit. I thank organizer once again for giving this opportunity. Happy to take any questions.
Thank you, Dr. Kripa. Very nice presentation. So, are there any questions? If they are not, then may I